Dr. It's a pleasure to be here, and really delightful to hear that last lecture. I think I learned more from this than I expected to. But what I'd like to do, Dr. Price has asked me to talk for about 20 minutes and talk to you about entrepreneurship and global health. And I didn't pick this title, so he picked it, so he's responsible for whatever I say today. But what I thought I would do, first of all, my disclosures are listed. I wish I had a longer list of disclosures, but I don't. Johnson & Johnson supports some of our programs in Nigeria, as well as some of the other companies that you see there. What I'd like to do for a few minutes is talk to you a little bit about the burden of global health, the burden of surgical disease in the world in general. As an academic, one of my jobs is training residents, so we're very interested in building surgical capacity in these countries, and so I'll talk a bit about the disparity in surgical capacity, as well as some of the opportunities in the private sector. And in the private sector here, the context is both for-profit and non-profit private sector, and I understand if those of you who are in academia, private is a four-letter word for us in real academia, but this really refers to both the NGO, non-profit, and the for-profit private sector, and what some people who study this think the future is going to look like in many parts of the developing world, particularly in sub-Saharan Africa. And then I'll share a couple of experiences I've had in the region as well. This is not news. Why do we focus on sub-Saharan Africa? Apart from our natural inclination to work there, it is home to some of the poorest and least developed countries in the world. Those of you who saw the lecture yesterday saw what I'm trying to describe. But in surgery, as far as burden of disease, there's this 90-10 gap which people talk about, and if you've heard this before, you can ignore it, but for those who haven't, the concept is that much of the disease, the burden of disease in the world resides within low and middle income countries, and unfortunately only 10% of the resources are available in those countries. So it's no surprise that there's such disparity in healthcare outcomes, including surgical outcomes. In the book that Dr. DeBass did a chapter on, the Disease Control Priorities book, people who are much smarter than I am have figured out that the surgical component of the burden of disease is about 11%, which is not insignificant as people talk about HIV and tuberculosis and some of the infectious diseases. Now, looking at surgery specifically, some of the folks at Harvard, and I'll show you some of their data now, looked at what the surgical output is worldwide, polling hospitals, looking at operations, and found that although many people live in these parts of the world that we're going to talk about, many of them don't receive the surgical care that they need, not because the need doesn't exist, but because the capacity doesn't exist, whether it's capacity in infrastructure or capacity in personnel. And they extrapolate that about 1%, the rates of surgery in sub-Saharan Africa are about 1% or less of the rates in high-income countries. And this is a graph from the paper by Tom Weiser, who was a fellow with that group that was published in The Lancet a couple of years ago. And the lighter colors are the areas that have operations. These are operations per 100,000 people per country. And the green ones are the ones that are more than 12,000 operations per 100,000, and the least are the less than 1,000. And you can see that most of the surgical output is in North America, a little bit of what I consider to be plastic surgery people in that part of the world. And then, the least people, the people who need it, who don't get it, are in, parts of Asia and sub-Saharan Africa. Barriers, my mentor Don Meyer used to tell me when I say there are barriers to traveling to this place, he said, what barriers? He spent 30 years in Nigeria, but there are clearly barriers. There are barriers of safety and politics and wars and conflicts and infrastructure. And I'm not going to go into all of that today, but what I thought I'd do is I think my personal view is that perhaps the largest barrier is the absence of skilled healthcare workers in these countries. So I'll talk a bit about that. And I'll show you that in some cases, in one of the case studies I'll show you, even when you have the infrastructure and the funding and all that, the lack of people who know how to take care of those patients is a huge barrier. This is a 2006 World Health Organization report looking in general at the distribution of health workers across the world. And what they did was they broke the world into different segments, compared the burden of disease, which is what you see on the vertical axis here. So how much disease is there in that part of the world? And on the horizontal axis, what percent of the total global healthcare workforce resides in those regions? And you'll see that on the top left-hand side here, these are the countries that have high burden of disease. 25 to 30% of the global burden of disease is in those countries, yet they have only 3 to 5% of the healthcare workforce globally. The other thing is that the size of these dots is representative of the amount of money that these countries or these regions put into healthcare. So the larger the size, the more money goes in as a percent of GDP goes into those countries. So between the combination of a high burden of disease, few healthcare workers, and very, very poor funding for those places, it shouldn't come as a surprise that the outcomes are terrible. If you break down those regions into countries that have a critical shortage of healthcare providers, and this is not just doctors now, this is nurses, pharmacists, dentists, community health workers, traditional birth attendants, anyone who takes care of sick people, you'll see where the critical shortages are. It's the same, you could overlay this on the other map and it's the same thing. It's in Southeast Asia, it's in sub-Saharan Africa, and then in some other parts of Asia. If you look at the numbers, and this is again is no surprise, the numbers are terrible in terms of numbers of doctors and nurses available, and they're in some cases less than a third of what most countries in the world have. And this goes across the board, whether it's doctors, nurses. The surgical workforce is a bit harder, more difficult to track because the data are not as good. But in the places where I could find data, because surgeons and the surgical workforce actually represent a small component of the workforce, the disparity is even greater in these countries. So the few countries I found data on, you can see sort of the sheer disparity. When we were in Sierra Leone in 2005, there were, I think, 4 surgeons for the country of 6 million, and you can see the same all over the continent. So I'll sort of switch gears and talk to you a little bit about my first case study, which is a hospital in southern Nigeria, Delta State University Hospital, that I became acquainted with about 4 years ago. And the current chief medical director, Leslie, is sitting here in the audience, so he'll correct me if I say anything wrong. But this was a hospital that, as you can see, it was a brand new facility at the time, built from scratch, with a lot of interest and resources. At the time that I heard about it, this was when it opened, these are sort of some of the construction pictures. I mean, this is just a short list of the equipment that was available there. Some of these things were better than the stuff I use in Dallas, I found out. But they had a CT scan, MRI, all the accoutrements of a tertiary functioning specialty hospital. And that's the CT scan on the left side. These are 2 brand new Olympus endoscopy units that we met there. And that's the ICU, complete with piped oxygen and suction and things that, I didn't even have where I work. So we thought this would be a wonderful opportunity to begin to work with them. That's what the operating room looks like. And they, as I said, one of the main issues was they lacked qualified people to run and manage the patients there. And did something I consider innovative at the time, was to try and recruit some people from the UK to come and help get it started. Sad to say, it didn't quite meet the expectations in the beginning, and I'll go into some details about that in a few minutes. But one of the reasons I think was that even when you had a few people, some of the people that you had locally didn't have the skill to take care of the problem. And in looking through the literature, this is a paper that summarized the results of a surgical skills workshop that was held in a different part of Nigeria for really senior level people. So these are not 2-year graduates so these people who had been in practice for several years. Senior registrars are generally, I would say, 5 years postgraduate at least. And what I found interesting about this paper was they pulled the participants of the thing and said, of all these procedures, and which of these do you have confidence First of all, the first column is which of these have you been exposed to? And then the second column is which ones do you have confidence in performing as a sort of mid-level surgeon? And you can see what I consider life-saving procedures, chest tube insertion. So if someone gets a hemothorax or a horrible problem, they can die from having a hemothorax. So that's a skill that we shouldn't really be discussing. Tracheostomy or vascular repair in terms of people who might bleed to death. And you can see the numbers in terms of confidence performing these. They're 4%, 8%, they're really less than half of them were confident to perform these. So the point of this is that even when you have the people, some of them are not trained to the ability of just taking care of simple things. We're not talking about laparoscopy now. We're talking about some of the basic essential surgical skills that you need. Going to laparoscopy, so speaking of laparoscopy, we did a poll at the West African College of Surgeons meeting about 4 or 5 years ago, just to poll sort of senior level people about how many have performed laparoscopic procedures, and the orange bars are none. And this is across the entire gamut, whether it's gynecology, general surgery, urology, thoracoscopy, and so on. So the capacity is a huge thing, and I hope some of those data have given you sort of a snapshot of what the issues are when it comes to capacity. I'll move on now and talk about private healthcare because this conference is about affordability, and Ray wanted me to talk a little bit about entrepreneurship and so on. And so in looking around at sort of what are the opportunities, what are the options, what are the barriers for business, I came across this publication, The Business of Health in Africa. It's a great read. It's a lot of pages, but it was funded by the World Bank Group, and the International Finance Corporation is a part of the World Bank Group, and they commissioned McKinsey to look at this, and it's a very comprehensive document that looks at 45 or more countries. It's not just literature reviews. They actually went to these countries and interviewed pretty much everyone they could lay their hands on that had any interest in healthcare. So it's, in my mind, it gives you sort of the most accurate picture of what private healthcare is or is likely to look like moving forward. And the first thing that jumped out was that their conclusion was that the expenditure on healthcare in sub-Saharan Africa will increase over the next 10 to 15 years. This graph looks at the growth rate. This is between 1996 and 2005, and this is the growth rate in expenditures. So this is just total dollars spent on healthcare in these countries. And then the projection between 2005 and 2016 is an even exponential increase in healthcare based on the numbers. Now, while most of us who work in sub-Saharan Africa think that most of the care is delivered by government or NGOs and so on and so forth, the truth is that much of that care is delivered privately. It's just not documented. And this is a graph from that paper looking at several countries: Mali, Uganda, Ghana, Kenya, Nigeria, Cameroon, Mozambique, Tanzania, Zambia, Namibia, and so on. And they found that in this orange column here, these are the segments. This is how much is spent in private versus public. And you can see across the board, the average is about 60% for all the countries that they looked at. So the private sector is already playing a part in these countries. It's just not been documented. And one argument as well, it's only the people who can afford to, the high-income folks in these countries who do that, and that's not the case. So this graph looks in 4 of those countries at the population in the lowest income quintile, in other words, some of the poorest, compared to the population in the highest income quintile, and you see that there's not much difference. As a matter of fact, in Nigeria, the lowest income quintile, 64% of those people seek their care privately. So some of this is just a crumbling infrastructure in healthcare in some of these countries, government infrastructure, and a loss in credibility that has driven people who can afford even a little bit of it to go into the private sector. It's not only urban folks, because if you look at the rural population in yellow versus the urban population in all these countries, about the same. It's also getting safer. This is an IMF thing looking at political stability and wars in the region between 1994 and 2004. And clearly there's been a trend in stability, and that has led to more investments, especially foreign direct investments. And I'll tell you that, even we were in Liberia 3 weeks ago, and I can tell you that there's been just a massive influx of all kinds of private, both for-profit and non-profit groups into the country. These graphs show you, give you a snapshot in many of these countries about, what the capital markets are doing, how much foreign capital has come into the countries in terms of foreign direct investment. These are the number of private equity funds over time in these countries. And interestingly, in some of these countries, there are some funds that are now focusing on the health sector. And initially, they started off with banking and telecom and so on, but I think they're recognizing now that there's a market in healthcare, and one just has to figure out how to get into that market. The summary from this document is that the need for new investment is what you see up top there by 2016. The largest opportunities for investment will be both in physical infrastructure and in human resource and health capacity. So they're projecting that in addition to all the new hospitals and beds and so on that are needed, there's a need for about 500,000 new beds or more. There's a deficit number of physicians, nurses, and community health workers that need to be trained, and that either the government or the private sector will have to do it. Interestingly, a colleague of mine who's the director for public-private enterprises in the Ministry of Health in Nigeria gave a wonderful talk looking at the deficit. And if all governments in the region spend what they're supposed to spend, which is 15% of GDP, that was agreed upon, there's still a deficit of 60% in health expenditure. So these governments will never be able, at the current rate, to fund healthcare, and so there'll be a need for someone else, whoever that may be. So the paper goes into a little bit more detail about, where are these opportunities. This is a typical McKinsey paper, by the way. If you haven't read it, it's very detailed. Where are the opportunities in the health sector? And they broke it down into projects. This is one of the graphs that looks at the size of the project in terms of the investment and the viability of the project on the top. And the size of the project goes from, $0 to $3 million. And then the size of the circle, I think, has to do with the market share. In other words, how big a problem is it? And the two that I'll focus on here are health services provision, which is one of the larger ones, and medical and education. If you look at health services provision, they broke that down even more. So you can start off with, a small investment in, telemedicine or one of these things, up to a large investment in high volume, low cost hospitals. And interestingly, they found several examples in Tanzania, in Uganda, in Nigeria, where people who start off with this high volume, really low cost options have been able to be profitable and provide a service that's needed at the same time. I'll talk about the small high-end centers here because Leslie has spent several years doing that, and that's my second case study. So several years ago, Leslie was visiting me in Dallas, and he said, well, we're trying to build a hospital. I said, well, I don't know that hospitals are the way to go in Nigeria. But anyway, despite all that, they got this facility up and running. So this is a place in southern Nigeria, in Port Harcourt, that Leslie, this was shortly after they started, with a lab, Leslie showing off his ultrasound machine there. But the concept was a really small, high-end medical center, 15 inpatient beds, a very small emergency room, basic imaging services, with the idea being that they would focus on just pick little pieces of healthcare and not try to do everything for everyone. And I think, he can correct me if I'm wrong, they were very, very successful in the first couple of years because the need exists. This was the first laparoscopic cholecystectomy that we did there in 2008. I did with Leslie, which thankfully went well. First one I've done in the region. But the idea is that they were able to accomplish this, and I think even now are able to provide many of those services at a decent cost, and he can talk about the details of financing and price structuring and so on and so forth. The McKinsey paper also goes through some of the other places. These are just some examples across the region of these areas. So as I told you, small high-end centers, there's a heart hospital in Tanzania, Lagoon Hospital in Lagos, which I hear is very good. I've never been. The Bridge Clinic in Lagos, and this hospital in Ghana. And across the region, you can see what their revenues are, what their setup costs are, and what they've been able to accomplish. And many of these, if not most of them, have been very successful. So I think it's a proof of concept. There are not a lot of them, but the few that are out there seem to have done well. In terms of affordability, you know, the sort of catchphrase now that is used is risk pooling, which is, the argument has always been, well, you know, most poor people can't afford to pay for those services. And risk pooling offers the opportunity to make those services affordable by sort of spreading the net wider about who you cover. And this is an example from Mauritania, looking at a flat fee coverage for obstetric care of $15. And what they managed to show here was that by pooling risk, which means taking all comers who are pregnant at such a low cost, a low fee, they reduced mortality. So maternal mortality for the people that had this insurance versus those who didn't was lower. And the use of the facility, the ones who had this insurance used it more frequently, which the impact of that is that you cover more women, you reduce maternal mortality. So the development impact was significant at such a low rate. And I think there are many places around the region now that are looking at ways to pool risk as a way of making services affordable. I'll spend a few more minutes talking about education. So, you know, my primary job is as a teacher, so I had to figure out a way to see if we could use the experience that we've had here over the years to provide education, because I still think that it's probably the biggest, weakest link for many of these countries. So the McKinsey paper looked at opportunities in medical and nursing education, same system, how much it costs to set up versus the impact and the viability. And you see here distance learning, schools for nurses, and then large universities. And I'll say there have been several successful large universities, although the setup costs are significant, but the need is so great that they've been viable financially. We've been involved, AMREF, as you heard earlier, I think yesterday, has been one of the sort of champions for distance learning for nurses in East Africa, and I think their program is probably one of the models I think should be expanded throughout the continent. Again, these are just some examples. One in Ghana, and AMREF I told you about in Kenya, that has really done very well using technology. And I'll share with you some of my personal experiences in trying to sort of get into the education business, as we say. I come from this place in Dallas, which, as I said, is a dyed-in-the-wool academic medical center where, you know, if you're not doing work on genetics, then, you know, you don't exist. But I initially, when I, you know, started reading about the lack of educational opportunities, I started looking for opportunities, and this was one of our first opportunities in West Africa. The Johnson & Johnson had this idea that we should teach this course called Advanced Trauma Operative Management, which was developed by a guy in Hartford, Connecticut, that's taught here to surgeons who don't normally take care of trauma, so that when they do see trauma patients, they know what to do. It's a very capital-intensive course, a live course with animals, equipment, and they decided they would do this, they would pay for us to go and do this in Ghana. We got there and we had a very successful course, and then I'm happy to say the course has now become a skills training center where most of the courses taught there now are taught by Ghanaians and don't require anyone coming from here to do that. The numbers still need to increase, but it's been one of the few successes in surgical education. And then, you know, a few years later, this was in 2008, when an organization I'm involved with, the Association for Academic Surgery, we had the opportunity to ask the leadership to see if they would put some money into doing a training course in West Africa. So the bottom line was, in collaboration with the West African College of Surgeons, which is the emblem you see here, we put on a course in Freetown, Sierra Leone, February 2008. Freetown had just come out of a horrible civil war. The president had just started in December. We were there in February. I think they got power to the city like on Christmas Eve, and so everything was still, you know, bullet holes in the things. But anyway, we had a course for surgeons who came from all over West Africa. And this course really, we've taught it here for several years, and it's really a research and career development course. And when we poll the participants, everyone says, you need to teach us some surgical skills. So we came back and we retooled, and then with the help again of Johnson & Johnson, we put on a second course in 2009, this time in Nigeria, and we added minimally invasive surgery in response to that request. And I'm happy to say that the AAS has continued to fund this course, and we just had the 5th course in Liberia in a small mission hospital, rural hospital, about 3 weeks ago. So those are some opportunities that sort of came up, and after thinking about it for a while, we said, well, we need to have some local entities or organizations that can sort of sustain this at the local level. So I called Leslie and Ima, who's an attorney, and said, you know, what do you guys think about this? And we decided that we needed to register some entities, and these are the 2 entities. One is nonprofit and one is for-profit, and the goal would be to provide healthcare skills training locally in the region and figure out how to cut costs and make this affordable. And since I think it was 2009, we have, with their assistance, begun to teach all kinds. We started off doing what we know, so this was one of the first minimal access surgery. You know, when you're a hammer, everything's a nail. So we taught surgery, but soon realized from the feedback that, you know, they needed other things. So now that's Leslie and Helen, who's one of the nurses from the UK, and that's the perioperative nursing course they taught last year. And we're doing more nurses now, I was telling one of the nurses. We're doing more nursing courses than physician courses because actually there are 3 times more nurses than there are doctors in the country. And frankly, I think in terms of support, we get a better response from the nurses than the doctors. But we've gone beyond surgery, and I think Leslie's done some cardiology and some other courses. And that's just a list of some other courses that they've taught. These are still institutional based, so the institutions pay for their personnel to attend the course. And it's still very expensive because you still got to get people to go down and so on. So what we did was we thought we could sort of use some technology. By the way, this is the last course that we did last year, and you may recognize this young man here. This was sponsored by Olympus, and Ray and I did, I don't know, several cases over a few days. But what I show this picture is just the sheer demand. This is the operating room during one of those cases, and it got so rowdy and hot that we had to send people to a different room and rig up this camera so that they could watch it from there. They're very hungry they've never seen this before. This is, by the way, is the first laparoscopic cholecystectomy in the hospital that Ray did. But they're very, very hungry to see this and to figure out what to do with it. And since we went, the surgeon there, Dr. Ludara, has done, I think, about 30 laparoscopic cases successfully. So that's a thing that I think we could, and we've supported him doing this. But as I said, you know, if you don't have Olympus or Johnson & Johnson, it becomes really tough because you really can't. What it costs to run a course is not something that most individuals can afford, even though the physicians and nurses are relatively well paid. So we began to look into options about using technology. We actually went through the process of you know, begging and borrowing, and eventually we got some used equipment from a company in Dallas that was getting rid of some video conferencing equipment that was 3 generations past. And we took it there. One of the challenges, those of you who've done this will realize, is that, you know, with the newer technology, it can manage low bandwidths, but the old technology doesn't. So after struggling, we managed, I don't know how we did this, but you know, with the internet going back and forth, we managed to get my colleague Mark Watson, who was in Dallas, to give a course on laparoscopic Nissens and colectomies, and it was well received. But it, you know, the challenges of internet bandwidth were still, we hadn't conquered those yet. And so we've been looking at ways to sort of reduce the cost and make this affordable. And a few months ago, I ran into a company The other thing about those telepresence or live surgery things is that you got to get that whole camera into the operating room. You got to put mics on the surgeon, and then on the other side you have to do the same thing. I ran into this company called Stream Venue Health, and what they've done is they've taken all that hardware and they've put it into a box, which you just plug into the back of a scope or a camera if the surgeon's wearing one, and they can get the audio and video over regular. You don't need a special thing, and it takes care of the bandwidth problems. So we've been in discussions with them. They use this locally. So the surgeon, they use this for orthopedics. So the surgeons basically decide, they just push a button on the thing and it starts recording and transmitting live. And even if you don't want to transmit it, you can store it in they call it an endo cloud. And then you can access it, which again takes the problem of timing away, because when you do courses 8 hours away, you have to make sure that the OR is ready here when you're ready there. So this, I think, will be something that I think will enable us. We haven't used this yet. We just got the commitment from the company to donate 5 boxes. And we're going to be looking at what kinds of procedures to use here so that we can cut the cost for this. It works very well, at least in Texas, where we've tried it. We'll see what happens when we get over there. And then lastly, I'd like to just say something about advocacy. I think for these ideas to stick, these are new ideas for our colleagues and partners over there, you know, the whole live surgery and the awareness about building capacity. We've tried to do some advocacy work, which means that basically we have to educate the medical directors of the hospitals, the government, the NGOs who traditionally have a place where they spend their money, to say they need to spend some money, some of their money on these initiatives. So we've done some media advocacy, which you see there. That was from the Abuja course. We're working with USAID. We were fortunate to get some funds from USAID. And this actually is we decided that sometimes even when we train the surgeons, some of the training that they got before they became surgeons is not quite where it needs to be. So we've gone sort of backwards to look at the curriculum of the medical schools. So USAID was interested in their capacity or health system strengthening program to put money into revising the medical curriculum. So we've been working with them for 2 years, about a year and a half, meeting with local partners and academics and all the stakeholders to revise the curriculum. In Nigeria, the curriculum is about 50 years old. It's the same curriculum that came from England 50 years ago. So they're supporting this, and I think by the end of this year we'll have a new curriculum that we're going to try in the 26 medical schools. We've also gone to the government. This is a signing at the Federal Ministry of Health with the current minister that we wanted to come and begin to help them increase awareness about training of healthcare providers as a way of improving health outcomes. And one thing, when you get involved with the government, you get really good at taking group photographs. So this is a photograph from that meeting with the minister, and basically all the people who are involved in healthcare in that country. And I must say that we've been well received, and so far they've been very supportive of these efforts. We're hoping that, you know, in terms of sustainability, the government is going to have to commit some resources to training, because even when you reduce the cost, there's just so many people that need to be trained that it's going to be difficult to do that without their support. So I will stop there and say I hope that I've been able to convince you about the problem of capacity and offer you some insight into what I've learned about the problem. So thank you for your attention.